All right, we are now live. It's Dr. Dan, president of the Functional Aging Institute, and we're jumping into the 11:15 a.m. Eastern time session with Dr. Michael Rogers from Wichita State. If you're on live with us, I'd love for you to type in the chat or the Q&A where you're tuning in from. We've got people from multiple countries, multiple cities, provinces, states, wherever you're coming to us from. I always like to see that. That's kind of neat to see that we're an international event. We're going to go really as long as Dr. Rogers wants to go, but we're going up till 12:30 Eastern. So this is set for an hour and 15 minutes. Hopefully we'll have time for Q&A at the end before he wraps up. So Dr. Rogers, if you're not aware of him, is a professor of exercise science at the Department of Human Performance Studies at Wichita State University. He's also the director for the WSU, Wichita State Center for Physical Activity and Aging. He's published more than 90 papers and made more than 400 presentations, regularly presenting in Europe and Asia. He's internationally recognized for his research concerning the effects of balance and resistance training on older adults. All of which is why, of course, we wanted to have you as part of this summit, Dr. Rogers. Thanks so much for being here. Basically, I'm going to turn it over to you. I'm going to hop off camera like I normally do. I'll still be here in the background. So if people ask questions or they raise their hands or you use some term that none of us have ever heard of, I'll chime in and say, hey, could you explain that a little bit more? Otherwise, we're going to let you do your thing and we'll do Q&A at the end. So thanks again for being here with us.
Thanks. Appreciate this opportunity. I'm glad everybody is able to tune in this morning. Learn a little bit about exercise interventions for active aging. Honestly, the Zoom thing is a little bit different. I've been teaching classes since middle of spring semester on Zoom, and I still haven't gotten used to it. One thing my students do is they play Zoom bingo, which basically bingo card, but it has squares for dog barking, UPS, FedEx deliveries, phone calls, babies crying, basically everything. And then by the end of the lecture, whoever scores bingo first wins. So if you want to play that, go ahead. I'm hoping to avoid all of those distractions, but that's kind of how I excuse them. I say it's for the sake of the game. Okay, let's get started then. And if I could advance, there. Okay, here's my summary of the aging process. We start young, we get to middle age, body changes, and then at the end, we just kind of conclude, well, that whole thing sucked. Question, why does it suck at the end? Why do we have that feeling? And oftentimes it's because we've gotten to a point where we're suffering from chronic disease, disability, frailty, many things that just limit our ability to enjoy quality of life. So a lot of what we're going to talk about today is how do we improve that quality of life in the later stages of aging process so it doesn't suck so much at the end. Well, a lot of it has to do with physical activity. Unfortunately, a large portion of the United States is inadequately active, or they are completely inactive. Over 3/4 of the population falls into that category, which is just astounding, but probably not surprising to you. And this insufficient physical activity is a problem largely in our society. If we look at other cultures, such as those in Asia, they tend to stay much more physically active, higher levels of mental and spiritual well-being, and a lot of this can be attributed to their levels of physical activity. I do a lot of work over in Japan where we publish BMIs for people, and we'll get responses from reviewers saying that your BMIs can't be that low for such a large subject population, and that's what they are. That can be 18, 19, 20. Or if you're doing an American population, they're typically 25 to 27. And that's, again, largely attributed to the lack of physical activity in the United States. So let's talk about a topic related to physical inactivity, and that's obesity. We've got millions that we consider over fat. We've got over 20 million we consider severely obese. It's not just an adult problem, it's also a childhood problem. And we recognize that it's inactivity as well as food intake that are responsible for this. So I'm going to go through a few slides here to demonstrate the impact of obesity in the United States. And I'm going to utilize the data from Behavioral Risk Factor Surveillance System that goes back to 1985. And you see many states here, there are no data that exist at that point. Was it 35 years ago? But you see the categories, less than 10% and 10 to 14%. And everybody falls into that category in 1985. So let's just fast forward a little bit. And we see obesity increasing a little bit. Darker blues, more dark blues, more data being collected. We're up to 88, 89, 90. We're filling in most of the states, but most of them are now 10 to 14%. And in 1991, we had a new category, 15 to 19%. 92, more of the darker blue. Now we've got all 50 states and a large swath through the middle of the country that's in the 15 to 19. And it keeps growing, 95, 96, 97, we're gonna add another category, greater than 20%. And you'll see in almost all these slides as we transition to a new category, Mississippi tends to lead the country. Now we've got more than 20%. That just filled in, so we get close to the end of the century. And at 2000, we're now 20%, and we only have one state that's less than 10%, and that's Colorado, which is typically the state that leads the country in the least amount of obese individuals. 2001, we add a new category above 25%, Mississippi. Alabama and West Virginia join them. Now nobody 10 to 14%. And we continue 2003, category above 30%, Mississippi. And we keep going. Notice California still 19%, 2009, 2010. So now happened over 20 years. And we went from largely 10% in 2010, we were 25 to 29 to plus 30% across the country. Just 20 to accomplish that. Now, the other thing that's going to happen here as we move on, they switch the colors on us. So to reorient, 30 to 35% is now the orange. And 12, Mississippi and West Virginia above 35%. And it continues 15, 16, 17, 18, and the most recent available is 2009. In Colorado and Washington, D.C., 20 to 25%, but a large amount for 35%. Now, not just the adult population. I think what's more into.
Hey, Michael, you're breaking up. You're breaking up just a little bit, and now I think you're gone. Hopefully we'll get Michael right back. I noticed his connection was getting a little shaky there.
Into racial differences, we see that Hispanics have
you need to reshare your screen again. So start that again. Since that would have broken up too.
Yeah, sorry. Just got to get back to.
If you start breaking up again, I'll chime in and probably it will help to turn your video off. But for now, I mean, your connection's good now. So.
Okay. There you are.
Yep, there we go. Cool.
Good.
Yep, I can see you.
Cool. All right. Uh, Okay, for the third time then on this slide. When we break the data down into racial differences, we see Hispanics make up a large population of the plus 35%. And if we go to non-Hispanic Blacks, most of the country is plus 35%. So let's see that it's big in the United States. Let's see where we are across the world, and we lead the world in obesity by far, and this probably isn't too surprising to you. But look at the difference between, say, the U.S. and Japan at less than 4%. Again, not much obesity there. The United States is number one. Now, what impact does obesity have? Because here I'm talking about obesity across all adults. Well, obesity is linked to a lot of different chronic diseases: heart disease, diabetes, blood pressure, arthritis, much more prevalent in the obese versus non-obese in people in their 50s and 60s. So I'm going to just make a point. How many overweight or obese 80 or 90-year-old people do you know? And chances are it's not many, because obesity is linked to not aging long. We also can consider, with the current COVID crisis, there's been studies that have shown that those that are obese have more profound symptoms, less likely to survive the disease. And this perhaps might be the reason that the United States also leads the world in not just cases, but certainly deaths from COVID-19. So this obesity issue has an impact as we get older. And a lot of it is because it is linked to chronic disease. Now, I could have shown those graphs, those charts of the states, not with obesity, but it could have been chronic conditions. It could have simply been the number of older adults. And what you would get a sense for is this wave that has been going on for the past few decades in terms of increased obesity, older adults, and chronic conditions. So now if we look at the number of older adults that have chronic conditions, close to 9 out of 10 have some chronic condition, from arthritis to diabetes, cancer, stroke, high blood pressure, heart disease. All of this, again, is going to get you to the end of the lifespan where you're like, yeah, it sucked because I got multiple chronic conditions. I can't enjoy what I have done for so long. Now, what might not be surprising to you is that exercise, physical activity, has a profound impact on prevention or maintenance of every one of these conditions. So if we take all of that together, we've got a number of chronic conditions. Those are resulting in functional limitations for older adults. This is resulting in decreased quality of life. And this problem, if we want to call it a problem, rather call it a challenge, is just going to get more profound. The number of older adults is going to increase dramatically, continue to increase over the next couple of decades. And with that, we're going to see these growing number of chronic disease cases. And I've sort of kind of given up given statistics on aging. I think we're kind of all aware of it, but it is sometimes just appropriate to say, hey, we got millions that have high blood pressure, heart disease, hundreds of thousands that suffer hip fractures each year. And again, physical activity has an impact on every one of these chronic diseases. So is it aging that's causing all this, or is it inactivity? And from a research standpoint, aging is not an independent variable. We cannot say that aging caused anything. Aging is simply associated with things, partly because we can't manipulate age. So from a research standpoint, we can't say that the aging itself is the cause. We can say that inactivity is largely at fault. So we see the same thing with inactivity as we see with bed rest. Same thing we see with space flight, lack of gravity, loss of muscle, loss of bone, changes in blood profiles, increased fat, loss of mobility from that loss of muscle. So let's focus now just on older adults. And after 65, many women and men are sedentary, completely sedentary, not just insufficiently active, but sedentary. However, the one and only significant intervention that improves overall health outcomes and quality of life in older adult populations is regular physical activity. So we could think of it in the ACSM, American College of Sports Medicine, uses this term, exercise is medicine. It's been said before, if we could take exercise and put it into a pill bottle, it would be the most popular medicine prescription ever made available. So we're going to talk about physical activity in terms of prescription during this presentation. But let's first, before we talk about how to exercise, let's talk about why people don't exercise. And many years ago, we went through and developed and identified barriers to physical activity. Why don't people exercise? And it can be attributed to some of the research that's not available, hasn't been done, problems in the home and community. For example, it might be a lack of safe environments, a lack of sidewalks, well-lit environments in the evening for people to go out and walk. It could be the workplace. Workplaces tend to be sedentary environments where you're sitting at a desk, be public policy, and it can be the medical system. Given today's audience, I'm going to focus on medical systems alone here. So why aren't medical systems equipped or able to deal with this lack of physical activity? Part of it's the lack of time. When you're in medical office, you only have X amount of time to meet with a patient before you move on to the next one. And you're dealing with their primary concerns. So you may not be taking the time to talk to them about their physical activity levels. It may be a lack of training and knowledge on the part of the healthcare provider, not being familiar with not just the benefits of exercise, but how to prescribe exercise, not having the materials or toolkits to provide to older adults to help them start an exercise program. It can be a lack of evidence-based best practice for those clinics. And honestly, it can also just be a lack of reimbursement. Unfortunately, there's very little money in exercise programming. There seems to be a lot of money in exercise equipment, but the key is getting people to actually use that exercise equipment. So this lack of reimbursement in medical systems tends to be a barrier as well. But if we identify barriers, we also have to identify, hey, strategies to address these barriers. So some of the strategies that we developed back when we did the National Blueprint on Physical Activity for Older Adults was to try to develop best practices and be able to disseminate those, and to figure out how to do patient referrals to community programs, as well as develop these toolkits that healthcare providers can give to older adults so they can go home and start an exercise program. And I'm going to talk about some of this during this presentation so you get an idea of how you can do it. So think about your scope of practice. You got promotion, you got provision. In promotion, we try to promote well-being, activity, education, and try to stimulate people to engage in these healthy behaviors. With provision, it's really about getting these exercise programs for older adults and programs to prevent chronic disease. So two parts to that. So how can we promote? As part of treatment, counseling, talking to older adults on how to increase physical activity. and talk to them about the benefits of being active. Be forthright with potential risks to an individual, and then find an appropriate program for them that deals with their chronic condition and their functional level of ability. And I also think it's important to be a role model. You know, you think about it, would you trust an obese personal trainer to guide you through an exercise program or a weight loss program if it doesn't work for him or her? You may not give it too much credit. So healthcare providers themselves need to be active and look like they are active. Walk the talk. And not to be overbearing on somebody. I mean, I'm not going to tell an older adult, hey, I'm running a marathon this weekend and why can't you be active? You got to relate to their level of activity and recognize how difficult it is to start a program and stick with it. You know, showing them that you wear an activity monitor so that it's constantly reminding you of how active or inactive you are throughout the day, so that at the end of the day, you've managed to collect your steps or burn a certain number of calories. This is important, very important for the healthcare provider to project this image of activity. Now with provision, you know, we're looking at wellness and preventative services, perhaps your community-based programs that are typically cash-based services. They're not really therapy. They're, again, community-based, where something like physical therapy is done through reimbursement typically and is deemed medically necessary. But you have a limited number of visits for physical therapy, and at the end of those visits, there really should be some outsourcing of individuals into an appropriate community program or a home-based program that they can continue on their own. So the role of you as a healthcare provider. It is extremely important that you have the knowledge and expertise to prescribe an individualized program that's safe and effective. And to be able to recognize those that may have complicating factors, these chronic conditions such as diabetes, hypertension, that can impact their ability to perform, exercise, yet be able to modify the exercise program, the prescription, to account for that. So being able to recognize those issues, you know, the healthcare provider works with the fitness practitioner and vice versa, where the fitness practitioner may recognize something serious and refer them. The healthcare provider may recognize this person should be involved in an exercise program and refers them to the fitness practitioner. So it's a two-way road there where communication is extremely important. Now get this, the most important factor for participation in an exercise program is a recommendation from a healthcare provider. Extremely important, where your physician says, really, we need to start you on some type of activity program. Yet, very few physicians talk to their older patients about exercise. Again, lack of time and other barriers that account for that. And especially those with heart disease, those that perhaps could benefit most from physical activity, most of them do not receive any information on appropriate physical activity that can improve their condition. All right, so let's focus then on how we can counsel patients and get them into physical activity programs. I'm going to cover a few topics here, the key components, the behavioral strategies you can use, but also identifying risk management. So what I like to tell people to do is use this AAA strategy. First, you're going to ask and advise, and this is going to lead into the behavioral change. Then we're going to assess. We're going to see what their risk is, see what their functional levels are, and then create goals. And then assist them, getting them into an appropriate program. So you just may simply ask patients during their medical history if they're currently active. And you can use this as a vital sign in their medical record. Just ask them, do you participate in physical activity regularly? What kind of stuff do you do? How long? How often? Are you active 30 minutes a day, most days of the week? Do you plan to become active if you're not active? Or other simple questions. Do you take the stairs when you can? Do you garden? A lot of people don't think of gardening as, say, exercise or physical activity, but it certainly can be. And then see if the patient is actually meeting the recommendations for moderate physical activity, at least 30 minutes a day on most days of the week. So there are some tools that you can use to help you. The Rapid Assessment of Physical Activity, the RAPA tool, has been designed for clinicians to quickly assess the level of physical activity in their older adult patients. And this tool has been validated against much longer, more complicated questionnaires. And you can download this, the website there, we have it at firststeptoactivehealth.com. But what it does is it gives you some examples of different levels or intensities of physical activity, light activities, moderate, vigorous activities. And then asks you, how active are you? I rarely do physical activities, or I do 20 minutes a day of vigorous physical activity. And then there's a way to actually score that so you get an understanding of how active they are, and you can more objectively measure activity levels in patients. And when you find people that are not meeting recommendations, that's where you take action and find appropriate physical activity programming for them. The other thing that can be important is just identifying where they're at in the stages of change. Stages of change were largely developed for smoking cessation. We've got 5 different stages that you go through before you adopt a habit and maintain that habit. So pre-contemplation, maybe you're unaware that exercise is good for you. Maybe you're unaware that smoking's bad for you. Or you might be afraid of exercising. Then you start to contemplate it, say, yeah, maybe it's a good idea, but I'm not really sure what to do. And then you might progress to the preparation stage. The preparation stage could be as simple as buying a pair of walking shoes. You're getting ready to engage. Then you take action. You actually put on those shoes, and you go out the door and you walk for a period of time. That's where we need to get people to initially, that action stage. And then if they continue to do that for a period of 6 months, we can put them into the maintenance stage. Of course, at any point, the maintenance stage could end. You could stop exercising and you fall back to preparation stage where, yeah, I got to get started again. I'm going to buy a new pair of shoes. I'm going to go tomorrow and walk. Now you're back to the action. And so it's not as if you reach the maintenance stage and you're there permanently. So there are a variety of flow charts available to identify those stages of change. This is just one example. So if you find that the person is not accumulating 30 minutes, are you accumulating at least 30 minutes at least one day a week? And if not, do you intend to? And if you don't intend to, you're in the pre-contemplation stage. So based on where you're at in the stages of change, you modify the behavioral counseling that you're going to use. Those that are in the maintenance stage and have been active for a long time, you don't really have to do anything with them. Maybe advise them to adopt some different activities and so on. Maybe it's balance training, which we'll talk about later. But it's those in the middle, in the pre-contemplation, contemplation, maybe even the preparation stage that you really want to get to. And those that might be in the action stage, it's a matter of figuring out how can you keep them exercising? How do you stay there? Setting goals, keeping them accountable so that they continue to do it. So try to recognize what the barriers are to an individual. And not everybody has the same barriers to physical activity. I've given you a few examples, but sometimes it might be fear. I'm afraid I'm going to hurt myself. I'm afraid I'm going to be sore tomorrow. I'm afraid I'm going to develop big muscles. There's a variety of these perceptions out there, fears, anxieties, and just got to talk to the person and figure out what those are. And this is part of your counseling. Just talk to them about the importance of physical activity and the impact it's going to have on them as they grow older, how it's going to help reduce chronic disease and disability and improve their quality of life. Now, I think this is an important point in how you talk to people about physical activity. AARP did a study a few years ago about the term exercise and found that it has a very negative connotation to people. Similar to like diet. If you were told you have to go on a diet, nobody wants to be on a diet. So we talk about eating healthy instead. Exercise can have the same impact. I don't want to exercise. I don't like that term. So if we use the term physical activity, it tends to be much more approachable. And this also will bring in other types of activities that we may not think of as exercise, gardening or dancing, for example. So the words you use can be extremely important and make an impact on your patient. Now, as you counsel them, try to provide very concrete and very consistent information. Make very clear recommendations. And I'm going to give you some examples of how to do that here in a few minutes. It is just not effective to say, you need to go out and be more active. Well, what should I do? That's what the patient is wondering. How can I do it? What's best? I don't even know what types of exercise an older adult should do. And I don't know, with my limitations, my chronic disease, if something's safe for me. So put some thought, some effort into it, but it will work. So let's start simple. Let's just recommend increasing physical activity to an individual that's in your office that's really not doing much. Some suggestions you can make. Walk rather than drive. Take the stairs. Start a hobby that's physically active, like gardening or hiking. Put physical activity into your daily routine. Maybe it's doing more housework, more vacuuming. Park the car further away at the store and walk. Play with your grandchildren. Walk the dog. I like the walk the dog thing. So Dr. Pierre Olaf Ostrand, famous exercise physiologist, would often say the best exercise prescription available is to adopt a dog and walk the dog every day. It's brilliant. You get home, the dog's there at the door, jumping up and down, asking, hey, I want to go for a walk. Take me for a walk. It's good for me, and I know it's good for you. This picture here is not what Dr. Ostrand was thinking. It's a lazy way of walking your dog. The benefits to walking a dog? Absolutely. You could assume there are because you're walking, but there have been studies that have shown that owning a dog results in more activity. So there was a study done a few years ago in Canada, dog owners versus non-dog owners. Dog owners walk nearly 5 hours a week, non-dog walkers 2.8 hours. So you can nearly double the amount of walking you do simply by having a dog. So adopt a dog. Remember to walk the dog at least once a day. And I will say during this period of seemingly endless quarantine, the one thing that's probably benefited the most in people's homes are their dogs, because their dogs get a lot of attention and certainly do get to walk a lot more. At least I know ours do. Okay, now, what we're going to do is we're going to recommend patients reach a goal of 30 minutes. Now, I think our field made a mistake many years ago when we put out this lofty goal of 30 minutes, and it was largely rejected because 30 minutes of continuous activity, one, seemed difficult, just in terms of effort, but also in terms of finding 30 minutes to devote to exercise at one point during the day. So I think it's been a good move in backing off that and letting people know that, hey, you can start with 5 to 10 minutes. Light activity, it's going to have some benefit, and gradually work up to 30 minutes. And also to take those 30 minutes and break them up into smaller segments, 10 minutes at a time. You have a short break, you go out and walk 10 minutes in the morning, do it in the afternoon, in the evening, you can accumulate 30 minutes by the end of the day. And that's much more approachable for a lot of people. Rather than thinking, hey, if I can't do 30, it's worthless to do anything. Do it in small amounts, accumulate 30 minutes, and perhaps get to the point where you can devote 30 minutes continuously to physical activity. So again, this notion of individualized programs, and we're going to get into the different types of activity here in a moment, but it really helps to have very specific written prescriptions that have goals and also have follow-up. So if you have a patient in your office and you're talking to them about exercise and you lay out what they should be doing, and then they're back in your office 3 or 6 months later and you don't even talk about exercise, it sort of gives the impression, hey, maybe it wasn't all that important. It's really important to follow up with them the next time you see them, or perhaps even follow up with a phone call, text message, and make sure that they're continuing to do that. If they have any questions, if they've developed any barriers to doing that, rather than have them back in your office in 6 months and they say, oh, well, on day one, I had this problem, so I just didn't do it. Follow up with them and put everything in writing so they have it. And for an exercise program, such as resistance training, having pictures and descriptions of the actual exercise. I'm going to give you some examples of that here shortly. Let's just talk about risk, though, very quickly. Certainly, there are some risks associated with physical activity. I think we need to recognize risks are much higher by doing nothing. It is more deadly to lay on the couch than it is to exercise. You're more likely to have a heart attack on the couch than while walking. So we know that this risk is going to increase as the exercise becomes more intense. So we want to focus on light to primarily moderate intensity exercise. We know there's a significant risk to benefit ratio for improvement with moderate intensity activity. And that should be our goal. Most people engage in some type of low intensity activity. And those can be performed safely. What have we often done or told people before they start an exercise program? You can see the disclaimer on every exercise infomercial on TV. Please consult your physician before starting an exercise program. Is that necessary? Does everybody have to get clearance from their physician to start an exercise program? And just this notion, convinced, has been a barrier to starting physical activity programming. There's really no evidence that screening before starting an exercise program is necessary. It should not be a prerequisite for participation, particularly in low intensity activities for people who are asymptomatic, regardless of age. So to address that, we developed a screening tool that I'm going to invite you to incorporate into your practice, and it's called the EASY, Exercise and Screening for You. developed specifically for older adults. And this is to let that older adult know when they should see a healthcare provider. And it is easy. It is simple. And it will work you through clearance and let you know, hey, I do need to visit somebody, or hey, I'm good to go. I can start exercising. And it's just 6 simple questions. Do you have pains, lightness, or pressure in your chest? Yes, no. Do you experience dizziness or lightheadedness? You've been told you have high blood pressure. And then it will follow up after that with, if you haven't had it checked in 6 months, see a healthcare provider. Do you have pain, stiffness, swelling? Do you feel unsteady? Do you use an assistive device? And then finally, is there any health reason not mentioned why you would be concerned about starting an exercise program? Based on those responses, if you answered no to all of those, it'll say, hey, here's 4 steps to begin or continue your exercise program. Choose enjoyable activities, 30 minutes a day, review the safety tips that are on the EASY website, and you can get a free copy of the NIA exercise guide. And I'm going to show you that here in a couple minutes. If you answered yes to one of those, it'll come up with a recommendation that you talk with your healthcare provider before initiating a new exercise program. And what's important is that the directions say, ask if there are any exercises you cannot do. Kind of putting the onus of burden onto the healthcare provider to say, hey, you shouldn't do this because of your condition. Otherwise, everything is possible. It's a way of screening people into exercise or physical activity rather than screening them out. Very effective tool to clear people to start a light to moderate level exercise program. All right, a little bit more on risk management, and we'll get to the exercise stuff. For those with chronic disease, we know that physical activity alleviates them. It can be very therapeutic. But for those, they really should be working with some type of fitness specialist or healthcare provider to develop those. There are conditions such as high blood pressure, rapid AFib that can result from exercise. There are certain contraindications to various activities, but the provider should be able to identify those activities that they need to avoid. And then simply just progress them from low to moderate activity. Try to increase the strength around their weight-bearing joints. Warm up and cool down can be helpful, and certainly prevent them from falling during exercise. Have your emergency plans in place. I'm not going to go into great depth and detail because I'm sure you all have these. You can go back and review the slide if you want, and just know your practice acts and your standard of care. You know what you're able to do, what would happen in court if something happened, and just document everything and have your insurance updated for yourself and your facility. And that's how you can minimize risk. All right, let's do some exercise stuff. Physical activity, we know it's a medicine. Every one of those conditions, it helps reduce and or prevent. So what do? Older adults wonder, what type of exercise should I engage in? And what we prescribe is a well-rounded exercise program. That's going to consist of cardiovascular exercise, things that get your heart rate and breathing up, flexibility, strength training, and finally for older adults, balance training. Now, I would not suggest you do any of these that are depicted in these cartoons in this fashion. Let's talk about appropriate activities for each of these categories. We did a study a few years ago over in Japan where we looked at these different modes of exercise and trying to figure out what benefits did each mode provide. So we recruited over 100 older adults and placed them into 5 different exercise groups: aerobic, resistance training, balance training, flexibility, and Tai Chi. And they engaged in those programs for 3 months, twice a week for 90 minutes a day. Maybe not surprising is only the aerobic exercise group improved cardiorespiratory fitness. None of the other groups had any effect on that variable or outcome. Upper and lower body strength as well as balance improved in 3 of the groups: resistance, balance, and Tai Chi training. And we had big increases in upper body strength, mostly with the resistance exercise. Lower body strength improved most with the balance exercise. And we had balance improve in the resistance, balance, and Tai Chi. So in resistance, balance, and Tai Chi, we get improvements in strength and balance, but no change in the cardiorespiratory. So we're concluding, a single mode of exercise can address multiple components of fitness, but not all of them. So a well-rounded exercise program may only need to consist of 2 types of exercise. One type needs to be aerobic exercise because that's the only type of exercise improving cardiorespiratory fitness. And the second type of exercise could be resistance, balance, or Tai Chi, because those will improve strength and balance. So combining 2 of those types of exercise, you can improve most of your fitness outcomes. So let's talk about some actual sample programming here. I'd mentioned the National Institute on Aging guidebook before. So you can access this at order.nia.nih.gov and just search exercise guide. Let me show you real quick. So this is going to be the website for nia.nih, and you'll see a bunch of different things, including participating in activities you enjoy. It's got posters you can use. There's a mini exercise guide. And if you just go up to this search bar and type in exercise guide, it will bring up this. Nice, colorful publication information. I did notice yesterday that they are sold out, but the entire PDF is available so you can print it at your convenience. So it's broken up into how to get ready, how to get started, and then actually doing it. How to include physical activity in your everyday life. Sample exercises, way to assess your progress, a little bit about healthy eating, and then staying in that maintenance stage and keep going. So I'll just scroll through a little bit so you can get an idea of this. A lot of text. I get set. How to get going. And then we'll get to the sample exercises. Endurance activities. Strength activities. How to use elastic resistance bands. And then some sample exercises that you can do at home. And I'll do this as well for the balance exercises and flexibility exercises. At the end, scroll down. Again, very, very good information, tells people exactly how to do the exercise with pictures, which is extremely helpful. How to assess yourself, this is the part about eating. And then activity logs, so you can keep track, goal setting worksheets. So this can be very helpful to older adults to have this publication and utilize it to start and continue a physical activity program. Another program, one we developed some time ago, is First Step to Active Health, which is available online. And First Step to Active Health contains a couple resources that you may find very helpful as a healthcare provider. And we developed this specifically for healthcare providers to start a conversation with their older adult patients, and materials to give the older adult to take home and continue an exercise program. So what the patient would get is a little packet of information, and it's got 4 fold-out inserts that provide the actual exercises. It has information on assessing yourself, goal setting, behavioral strategies, and activity log, and comes with an elastic resistance band. So again, we're talking to the older adult directly about the importance of physical activity, what your needs, your goals are, how to progress, and how to use this information along the way. In addition to the toolkit, there is a white paper and a provider manual. These are specifically designed for the healthcare provider to provide them with the knowledge and information that they need to hold this conversation with their older adult patients. And this is available at firststeptoactivehealth.com. The assessment part simply is the functional limitation assessment I'll show you, or the senior fitness test. All things that can be done in clinical office. The functional limitation checklist you can see is, do you have difficulty getting dressed, picking stuff up off the floor, getting out of a chair? And then on the right side identifies the activities to emphasize to overcome those limitations. And it's part about making this physical activity relatable. How is it going to improve my everyday life? So maybe it's a problem with carrying groceries. So your goal is to carry 2 bags from the car to the door without strain. How are you going to accomplish that? It's going to be upper body strength as well as balance training. That's what you want to focus on. We create very simple goals and then relatively simple activities they can do to improve that functional ability. Senior fitness test, I'm sure most of you are familiar with, consists of the chair stand, arm curl, 2-minute step or 6-minute walk, flexibility assessments, and then the 8-foot up and go for balance and mobility. These largely can be done in a clinical office, and there are norms available to show where limitations, weaknesses, deficits exist that you can target with physical activity. Toolkit comes with a sheet for goal setting. So write these things down, make people accountable. And this can be a nice thing to bring back. The patient brings it back to their healthcare provider during their next visit to show progress and maybe update their goals. List of safety reminders for them. Again, risk management. Some exercise hints, how to make it more comfortable, more doable. Everything from hydration to clothing. Ways to stay motivated. And then gets into the actual programming. So the cardio activities suggest that I've mentioned before, taking the stairs, walking the dog, using a pedometer to count your steps and working towards a certain goal. Maybe it's 10,000 steps a day, but with a gradual increase towards that. And trying to get to that point where if you introduce them to the Borg scale, an RPE scale, where it's moderate intensity, where they can still hold a conversation as they're walking, but their heart rate and respiration is elevated somewhat. So education is important. Let the person know why they're doing it, what they should do, when they should do it, how often. In this case, 3 to 5 days of the week. And then give them specific examples of what they can do for cardiorespiratory activities. This could be treadmills, cycle ergometers, all the equipment you may see in a fitness facility, or again, simply walking. Very cheap, very effective form of physical activity. Flexibility, again, the why, what, when, how to start, how to advance, and then specific examples of flexibility activities. Just starting with 5 to 10 stretches for the upper and lower body. Hold that for 10 to 30 seconds, do it 3 to 4 times, something you can do while watching TV. And then giving them the pictures and the descriptions for each activity that they should be doing. Strength, again, the background to it, 2 to 3 days a week, how to start, how to progress. And this is based off studies that we've done before, myself and others, that show that this strength training program utilizing elastic resistance bands can increase strength, balance, gait, and function. All of these are connected with functional tasks. So strength is extremely important. Even ACSM recognized this many years ago in their recommendation saying, hey, you know, before you walk around the block, you've got to be able to stand up from the chair. So you have to have the strength to stand before you can engage in cardiovascular exercise. So strength is extremely important and probably one thing that does limit independence as we get older. So again, specific exercises, pictures before and the start and the end positions with the description of how to complete that. So we're looking at 8 to 10 exercises twice a week, starting with 1 to 2 sets, and for older adults, 10 to 15 repetitions. And this might take 30 minutes of the day, but it can be something that's done again while watching television. And then gradually increase the repetitions. Once you get to 15, increase the resistance, so you're only doing 10. Be sure to remind them that they should not hold their breath and just relax while they're doing it. People can use hand weights, resistance bands, or just no weight at all. Depends on their ability and what they have access to. So it's the example of some of these exercises, almost all of which can be done while sitting in a chair. So if you have somebody that is more frail and less able, they don't have to stand to perform these exercises. More able people can do them in the standing position. What you can use, household items such as soup cans, very cheap exercise equipment. And the picture on the right is actually taken from the NIA Guidebook, woman using soup cans for an overhead press. I like elastic resistance bands. One, they're inexpensive. Two, they don't take up much space at all. And they are relatively easy to use. And with a single elastic band, you can recreate anything that you do in a fitness facility. Most older adults don't have access to weight training equipment, or they're reluctant to go to a fitness facility. They have fears about it. They don't want to be next to, you know, the big bodybuilder lifting a lot of weight, huffing and puffing. You know, they'd rather be with older adults in a much more calm, what they perceive safe environment. So with elastic resistance bands, probably familiar, they come in a wide variety of resistances. So you can identify which color band they can use to get those 10 to 15 repetitions. And once they reach 15, increase to the next color. Must mention, I focus on risk management here, but I think we have to be. Just realize that these are elastic, they can snap. That's why it's important to make sure that elastic resistant bands are in good shape. It's recommended that you use some type of eye protection, because if you're pushing away from the body and they snap, that's coming back towards your head. Another advantage of elastic resistance, that can be used in a swimming pool. I like to give those to my older adults, and they can take them when they travel. They can take them when they go see their grandkids. They can take them to the park. They can do their exercise program at home. Here in Kansas, we have days where we have to cancel classes because of weather. But if they have a band at home, they won't necessarily miss their exercise routine. They can do it on their own. They also don't take up much space. You can just put it in your pocket and go where you want. Another great advantage is you can do them in groups. And this adds to the social benefit of exercise for individuals. You can't accomplish this in a fitness facility where everybody's using their own piece of weight equipment. And the number one reason probably that people, older adults, exercise in general is the social interaction. That's what brings them back. It improves their mental health. A lot of these people are living on their own and they don't have social interaction to a large extent. And this becomes their way of achieving that. So I do not use terms like arm curl. Arm curl is really just about lifting objects. So it's about lifting up your grandkids. Reaching forward is not the bench press or chest press. It's pushing a door open. And then other examples, pressing up, pulling back, chair walking, improve those hip flexors, leg press, which is really about getting up out of a chair, improve the strength of the quads and the hips and be able to stand from that chair so you can walk. Standing from a chair, which recreates that standing up from a chair activity with resistance. And toe lifts. Hard to find an exercise machine that does this, but by lifting up that toe with resistance is increasing the strength of your tibialis anterior, which is required to lift your toe up off the floor, prevents you from tripping over something. Very important. And then we can recreate functional activities, pulling weeds from the garden. Finally, balance. And balance is something we basically take for granted in our younger years, but as we get older, it becomes really a health concern because it leads to falls. So how do we do balance training? Why is it important? You know, 1 out of every 3 older adults falls each year. And with over 10 million falls and almost 2 million visits to the emergency room, 300,000 plus hip fractures, balance is extremely important. Falls are not caused by osteoporosis. Falls are caused by a lack of balance, and then the hip striking the ground causes the hip fracture. So balance can be poor balance can be a leading cause of not just morbidity, but also mortality. Challenge with balance is it's so multifactorial. A lot of things that go into balance, including your vision, your vestibular system, your sense of touch and pressure, your somatosensory system, as well as your muscular system. So these activities, again, based off our Standing Strong exercise program, it's a multi-component approach that addresses balance and strength training, gait and weight transfers, and risk management. You're doing balance training, there's a chance you can fall. And this program is about fall prevention, not fall promotion. So most important thing is to have something sturdy in front of you. Whether it's a countertop or a chair without wheels is important. That they can grab onto or put their hand on while they're doing these activities. And for high-risk individuals, they should not be doing these at home by themselves, because if they suffer a fall, there's nobody there to help them. So just be a little cautious. So here are some examples. Tandem stand, where you're simply putting one foot in front of the other, and I welcome you to try any of these. Even while you're watching this presentation, stand up. Notice, put your feet side by side and see how much you sway. Then put one foot slightly in front of the other in a semi-tandem position. See how much you sway. Then put your heel to your toe and see how much you sway side to side. To make it a little more difficult, close your eyes while you're doing that. Again, you got a countertop in front of you or desk you can grab on if you need to. One leg balance, when we can get into some dynamic movements, raising the legs, raising the ankle, kicks, and then we can introduce foam. Standing on some type of soft surface, which requires a lot more balance control. So here we are with tandem, static balance, tandem, one-footed. Then we move to foam. I actually created this exercise program with foam because I was changing a light bulb on our ceiling fan over our bed and realized how unstable I was as I looked up at the light fixture and thought, hey, you know what? If I put older adults on foam, we might have an exercise program. So I went out and bought some sofa foam from an upholstery store, and you cut those into 18-inch squares, and that was our first exercise program for balance training. Foam is very effective. The dynamic balance, where you're moving the legs back and forth, we can add resistance to those. We can add dynamic balance activities through walking on the toes, the heel to toe walk, crossover walk. And we can even do that on a foam mat to make it a little bit more difficult. You can introduce exercise balls, a variety of different activities that go well beyond doing these things in a chair, and then incorporate the elastic bands and the foam to create more dynamic functional movements that incorporate multi-joint activities. And then even recreate sport-specific activities that involve balance, like the golf swing, and we also use it for tennis. So the toolkit provides stuff on how to progress through the program, how to increase resistance, duration, frequency, and then a way to record what you do. And this, again, is important for sharing with you as the healthcare provider. They come back and say, this is how much I've been doing. What is this good? What do you suggest? Should I change anything? This helps document what they have done since you last saw them. Look at the time real quick. Yeah, this is important enough. I'm going to skip my next section, but I'll do this real quick. What do older adults want? They want safety. They want to know how to stay motivated. They want goals. They want a plan developed specifically for them. They want resources. They want stuff they can do at home, not just in groups, but at home. So what are the characteristics of a long-term program that works? Low or no injuries. Groups help a lot. Make it fun. Give it variety, so it's not the same thing every time. Focusing on their goals, assessing them. Assessments provide feedback. It shows improvements, whether it's in strength or balance or any of those outcomes. Positive feedback, enthusiasm, and role models. So when you're talking with older adults, and this is more really in the for fitness practitioners, again, use physical activity, not exercise. Try to use the term older adult, not elderly. Elderly is much more derogatory. Older adult is more appropriate. Senior citizens, also a term of the past. Older adult is most appropriate. Use appropriate volume, pace, so don't talk too quickly. Don't use slang. Make eye contact. Talk to them as a real person, and use real life examples. Again, the examples of the strength training and relating it to functional abilities makes it very clear why they are doing those activities. Figure out ways to get them to return, whether it's rewards or, hey, come back, we're going to be doing this next time. Don't scold them. Don't patronize them. Promote socialization outside of exercise time, coffee hours. And use perhaps even older adults as your leaders. I've had great success in training older adults and having them lead exercise program at senior centers. And that really helps recruit other older adults into the program. I can skip. So whether it's you're using the NIA book, you're using our toolkit, you're using any type of exercise program, where and when do you implement this stuff? At discharge from inpatient care, outpatient clinics, in medical fitness facilities, gyms, clubs, nursing homes, retirement communities, senior centers, any place where you're working directly with an older adult, and there's a variety of those situations, they're open to learning about how to be healthy. You just have to do it in an appropriate, safe, and approachable way to get them going, and then find a way to hold them accountable. I'm going to skip my special populations for the sake of time. And I'm going to finish with these two slides. I'm going to come back to this one. And you're about an hour and 15 minutes older than when I started this. And I'm really hoping at this point, you're not to the point, well, that sucked. I'm hoping you found at least one thing out of this presentation that you can use in your practice. And if not in your practice, in your own personal life. As you get older even, you may come back to this 20, 30 years ago. Hey, I remember these strength balance exercises. I'm going to use those now. Hopefully you found something that's useful in all of this. If you have questions, comments, that beyond our limited time here, there's my email address. I can even send you the toolkit exercise handouts as well, so you have those. Just drop me a note, ask me what you want, and I will send it to you. If you can't find the NIA guide, I can email that to you as a PDF. Please do not hesitate to contact me with your questions later today, this weekend, or anytime in the future. But again, I want to thank Dan and Cody for the opportunity, and the rest of the organization for this. And at this point, I'll entertain any questions or comments.
Awesome. Thanks so much. Yeah, Carrie Hollywood says, thank you so much. A couple people did ask about your slides. I don't think you provided us a PDF yet.
No, but I can send that to you.
Okay. If you could do that, we will post that on the site. We're putting those with the speakers sessions and with the recordings. So I know people watching the recording later will be like, oh, can we get the slides? So yeah, if you could send us a PDF of whatever portion of that presentation you want to share, that would be awesome.
Absolutely.
That'd be great. Yeah, a couple more people saying great presentation. Thank you very much. We'll do questions here for the next five minutes or so. If you folks have questions, I know some people are looking to get to lunch. People are excited to get the PDF. Great. We've done 2 sessions back to back, so people are probably ready to go to the bathroom, get a drink, get some lunch. So I love the walk the dog stuff. I have a golden retriever, and she loves to be walked all the time, anytime, is always up for a walk. You have to spell the word. I think she's figured out W-A-L-K means walk.
Yes.
So,
yes.
And I would say with COVID, I mean, it was way easier all of a sudden to get in my 10,000 steps and walk 5 miles a day. And, I just had more availability and time. I was like, hey, Finney, we're going for a 3-mile walk. Here we go. And she's always up. So that's kind of cool.
We've had a bit of a challenge in keeping our older adult participants accountable. Because, when all this happened back in March, we were kind of stuck with no plan. Our participants couldn't come to the senior centers or onto campus. So we started turning toward Zoom classes, which have worked very well.
Yep.
And having people able to use the elastic resistance bands at home has definitely helped. So we've been able to keep in contact with nearly all of them and continue having them do their activity programs. We're looking forward to getting back in person, hopefully soon. But yeah, it's been a big adjustment.
Oh yeah, for sure. Yeah, at our facility, we have people working out outdoors. We have people that are willing to come to the facility, and we still have people Zooming and training virtually and every which way. So the one nice thing about
situation's sort of been, I mean, in some sense, a blessing to our field because we've had to diversify. As I know for us, we've been talking years, well, we could do some of this online, but there's never been a real impetus or need to have to do it. So it just gets pushed.
Yeah.
And then all of a sudden, we got to do it.
Yeah. I know so many trainers and fitness studio owners are like, well, I was meaning to do the online fitness thing, and now I guess I'm doing it starting tomorrow, right? So, I mean, they get shut down and you're sort of forced to adapt. So, well, I don't see any more questions. More people thanking you for the info and presentations. If you're on the recording, Michael's given you his email address here. Feel free to take advantage of that. I'm sure he'll be a great resource for you. So don't hesitate to email him if you have questions or comments, or if there was a handout or an organization you wanted more info on. He's a wealth of knowledge. So Dr. Rogers, thanks so much for contributing to our summit, and we'll see you all back in about 1 hour. We are now on a break for lunch. So see you, everyone.
Thank you.